Now with this patient, so we've got some, even with our nutritional support, there is some, muscle loss and malnutrition. So now the patient has been transferred to the floor. So this is outside of that window of critical illness. He still has short bowel and on TPN. I wanted to spend a couple of minutes talking about the next stage in his care on the regular nursing floor and preparing for home. Sarah mentioned a little bit about this for preparing the PN script, but now that we're out of that critical illness stage, we're really working on recovery, and that's working with our improving functional status, with our physical and occupational therapists, and discharge planning. When we want to discharge patients on home PN, there's a lot of things that you need to think about that we wanted to highlight here. One is the home environment. So I've had some patients, you really have to establish where they're living. If they can't walk up the stairs and their bathroom is upstairs and they're going, and that's where their bedroom is, you have to kind of accommodate their living situation. In addition, I've had some patients who live in rural situations where their electricity is not very in upkeep. I mean, in Cleveland, we had a tornado 2 years ago and the power went out, and we got a lot of phone calls from our home PN patients that they don't have fridges to keep their PN scripts. Things to think about that certainly I didn't get in my medical training, but certainly working with a multidisciplinary team with their case managers and on the floor were PT and OT. What's the caregiver home health situation like? Are they able to get access and care? I've worked in institutions and environments where patients had nursing available to them to hook up and hook off. At our institution, a lot of times that's independent for the patient that they have to do that or have a trained caregiver to do that. You can imagine some of these people are not medical, and this is very overwhelming for them. So in some situations, we have to think about discharging them to a skilled nursing facility or a rehab situation to get them a little bit more stronger and comfortable with PN. A lot of this education around line care is so key because we think about line infections and preventing catheter-related line infections on the outpatient setting. A lot of that is with education with the a patient and their caregivers. The PN script also has to be timed for homegoing. So a lot of times in the hospital, it's over 24 hours. That's not very feasible in the home setting. So generally, we want to try to get weaned down the time to about 12 hours. We always provide extra IV fluid bags, especially in new short bowel patients, because of their fluid shifts can be so drastic, and make sure that we avoid dehydration in the outpatient setting. Insulin, Sarah mentioned this a little bit. There's a lot of work with our endocrinology team to see how much insulin is required in the bag to maintain their glucose levels while they're on PN, but a lot of the times this gentleman has type 2 diabetes, and if he's eating throughout the day, he might need more short-acting or even long-acting. And so we work with a lot of my patients with type 2 diabetes with the endocrinology team to make sure that we have adequate glucose control. And of course, you need a managing provider. So you can imagine that it might be challenging for a lot of out-of-patient stations. And then again, not only the home environment, but where do they live, what access to team that they have. There are some center of excellences in the US that will manage PN, but it's a little bit challenging for patients who live in areas that don't have good access to care. And certainly in my institution, we do manage patients from out of state, but it's a lot of effort and a lot of work and resources in managing those patients appropriately. I won't touch on this too much, but give a little brief overview on the medical management of short bowel syndrome. We could do a whole other talk on that to go through with that. So I want to highlight here that ASPEN has presented some safe care transitions and a little bit highlighting of looking at when to provide the PN and then working on that home setting, identifying the receiving organizations, accountable providers to manage the PN, communicate with the PN care plan, and then implement the PN care plan. And this is a new start of HPN and how we start transitioning the patient. But we do have a lot of patients, if they get sick and they go in the hospital, we're working a lot with peripheral hospitals and managing them and resuming them on their home formula. So this patient, post-hospital stay, so we always want to like to see them very quickly. You can imagine this, a lot of hospital readmission rates or complications of home PN can happen in the first month or so of starting PN. So we really have established discharge clinics to really see these patients quickly, check in on re-education on line care, and check on how they're doing and adapting with PN in the home setting. So this patient is tolerating PN quite well. Blood work is stable. We always check the central line and how they're using their techniques, which is good, and then adjusting to the PN administration at home. You can imagine, and there's been a lot of literature on this and quality of life with PN in the home setting, and I think the number one reason is they don't like the pumps going off overnight, or they have to get up to use the washroom, because this is very impaired sleep and rest and recovery. This patient, we didn't delve in this too much, but the patient was able to advance his diet by mouth. Sometimes we do PN to EN and then oral intake, but in this case, we did challenge him by mouth and he was tolerating. The biggest thing that when we see these new short gut patients, we talk about their liquid intake. So a lot of them have quite a high thirst drive with those fluid shifts, and a lot of them drink water. So this gentleman was drinking 2 liters of water, and I'm from Canada, and there's not a lot of pop or soda intake, but I'm finding in the U.S. people really like their sodas. So he's drinking a liter of soda today. I have a lot in life to go to the CEO of these soda companies and put them out of business. But anyways, but that's the feedback that they get, and the number one thing for these patients that they say to me, they're like, Dr. Russell, I'm so thirsty, and they're chugging these water and they just can't get ahead of it, and we'll talk about that a little bit. Output is high, 2.5 to 3 liters. This is 160 centimeters. That's kind of what we expect in this initial phase, but certainly it's a little bit high and not optimized that we can try to help with. So we talked about intestinal failure. Remember, type 1 is that acute. Subacute is kind of in his hospital stay, so now we're in that chronic type 3 stage. So this is generally metabolically stable. This is months to years out, and generally can be reversible or irreversible. This gentleman, as I mentioned, has type 1 short bowel syndrome. So you really want to work on dietary changes, medications to help with the output, and some surgical management, which I'll highlight. I like photos. So this is always in my mind as well. So after surgery, that adaptation period, a lot of that adaptation does happen in type 2 and type 3. But even the type 1s, they go into this hypersecretion state, especially post-op, so they can level out with their output. And I mentioned this last night in the medical practice section, is that no short gut is the same, and people will surprise you. And we do look at anatomy and see predictions of what they need for their IV support, but really people will surprise you, and you have to cater with their needs individually. Very briefly, short bowel management. At this point, we would continue the parenteral nutrition. We generally work on the diet. So we have a team of specialized dietitians in my institution that work with short gut and rehab. And the key takeaways for you is multiple small meals a day, separate liquids and solids, high quality protein throughout the day, and limit concentrated sweets like juice or pop or desserts, and really use that complex carbohydrates with meals. We have some patients that we use medications, which I'll highlight in the next slide, but they actually find that some complex starches like oatmeal and potatoes work just as well. So that's kind of using food as medicine in a way to help manage their output. Micronutrient monitoring and supplementation, as Sarah highlighted, this is really important in short gut, whether they're on PN or not. And that oral rehydration solution is the mainstay. I can tell you we've been working with chefs to help with the taste of it. It's very salty. But the recipe is there for your reference. And the key is that we want that ratio of salt and sugar to help with that SGLT1 receptors in the small bowel to help with water absorption. So it's not like the colon. The colon has aquaporins that can absorb water directly. In the small bowel specifically, you need that ratio of salt and sugar for absorption. I like to tell patients that plain water with no electrolytes or soda that has high sugar without that salt, it's like drinking liquid plumber. It will just go right through, and that's what they see and experience. It's really challenging because everyone grows up with that dogma that water is for hydration. I even caught some primary cares and other physicians recommending that as well, so it's a lot of education for this. Short bowel management for medications, we have a lot at our arsenal to use, so antidiarrheals, pyramide or codeine. Different institutions I've worked at with different availabilities with their insurance to get these covered. Bile acid resins are helpful for the type 2s because you're missing that ileal brake and you have the colon. Stomach acid inhibitors, proton pump inhibitors, or H2 blockers are used, especially in that hypersecretion phase. Antibiotics for these patients suffer from small bowel overgrowth, and digestive enzyme supplementations are appropriate in some patients. And then growth hormones like teduglutide is a glucan-like peptide 2 analog, and that has been used in the STEPS trials to look at people who are on PN with short bowel intestinal failure for over a year, that they've been able to wean their PN in about 63% of patients. But interesting, if you look at that paper, 30% of patients weaned on their own as well. So generally in our institution, we do not start teduglutide right away, especially in that adaptation phase. We really want to let things level out and see where that patient is at, because a lot of the times with aggressive dietary therapy and aggressive medical therapy, patients are able to wean their PN. So in my practice, we generally wait typically 6 to 8 months, really maximize and see what they're doing to wean them. But I have some patients, I tell them, like, I can throw everything but the kitchen sink at you, but if you're drinking a liter of pop a day, that nothing's going to help that. So it's a lot of education and behavioral changes for these patients to work on those diets. And we have one patient, they're about 70 centimeters to end jejunostomy, and he's off PN. But this guy eats every 2 to 3 hours, and he drinks ORS, and he wakes up at night and drinks that because he's trying to wean off of PN, and he wasn't a candidate for these growth hormones. So it is possible to kind of adjust your therapies for the patient's needs, but you have to be realistic, because if they're going to eat cake and drink pop, then nothing's going to work. This is briefly some ASPEN guidelines on long-term monitoring for blood work. For acute care, of course, you want to do them more frequently, but in that long-term PN where things are stable, then generally we check electrolytes and CBC, and then there's different recommendations for the micronutrients that I left for your reference there. So we have come to the end. We tried our best to jam-pack all our principles with PN, EN management, and short bowel syndrome. So it was a little bit rushed, but please forgive us for that. But it's a tough topic. So remember this gentleman. So this is a gentleman with 72, type 2 diabetes, hypertension, dyslipidemia, obesity with GLP-1, with weight loss, enterocutaneous fistula, and neck fascia of the abdominal wall, 160 centimeters remaining, and then discharge on home hospital, and kind of outpatient management there. So practical implications we're hoping to highlight with this case is that you kind of look at where they're coming from. Like Christan said, it's day one in your ICU is not day one in their journey. Feed early and appropriate. Look at hypocaloric and high protein in the PN. Day one is not necessarily for the patient. High protein, low dex calorie for critically ill obese. We talked about optimized blood glucose control, volume electrolytes, and use the GI tract, and optimizing PN for homegoing. And then I did a brief overview on HPN management and then outpatient management of short bowel. So here are our key takeaways here. So as we talked about early targeted PN or that supplement PN in patients, evaluate their malnutrition status. There's some questions online about what we are using for guidelines, and then using the use of tools to adjunct evolution of ICU journey, and then PN prescription and close monitoring, and then long-term management of short bowel syndrome.